Okay, yeah, so welcome everyone to this edition of the Global Medical Physics Education Lecture Series. It's very much my privilege to invite Dr. David Flint to give a talk on RBE modeling in ion therapy. So David did his bachelor's degree in physics and chemistry at Carleton in Canada, and then did his PhD in medical physics at MD Anderson, then stayed for a postdoc, a residency, and soon to be faculty at MD Anderson in about 2 or 3 months. But yeah, David has worked in RBE modeling for over a decade, so he definitely is an expert on the topic. So I look forward to hearing what he has to say.
All right, thanks, Joe. I guess I'll just jump right in. Yeah, so I guess just to begin, to give you a quick overview of the things I want to touch on today. So I'm just going to give a very brief introduction to ion therapy generally, just to make sure we're all on sort of the same page and being able to distinguish what we're talking about compared to photon therapies. I'll go into some of the physical and biological drivers of RBE, and then I'll more specifically discuss some of the RBE models that we currently use. So there's a couple of mechanistic models that we actually use in the clinic for carbon ions, and then a few proton RBE models, which are not currently in use in the clinic, but I think are worth discussing. And then I'll just offer a few concluding remarks. So, just to give you a brief, 10,000-foot view of radiation therapy with ions, as I tell my friends who are lay people, basically what we're doing here is we're using a particle accelerator to treat cancer. So we start by injecting ions. So currently it's usually protons or carbon into a synchrotron, which accelerates them to near relativistic speeds. And then once they're high enough energy to be therapeutically useful, we direct them down a long beam line using bending magnets towards one of usually several treatment rooms, where they're then directed towards a patient who is aligned on some sort of treatment couch. And oftentimes we have some sort of gantry system, like you see here on the bottom, which can rotate around the patient and deliver the beam from several different beam angles, kind of similarly how you would deliver a photon treatment, although in a much larger scale. And so the major drawback of trying to use this technology is simply the cost. These systems are orders of magnitude more expensive than X-ray therapy with a linear accelerator, or if you're using cobalt 60, it's far more expensive than that. And that's really just because you need to build and then also maintain a particle accelerator, and that is incredibly expensive. That being said, ion therapy is becoming increasingly more prevalent year by year. So there's now over 120 facilities around the world. And as you might expect, with their great cost, the majority of these facilities are in the US, in Europe, and also in Japan. Although there's many more under construction, and there are facilities popping up sort of globally. So it is, I guess, encouraging from those of us who are interested in ion therapy that we are getting more and more facilities sort of around the world. But you might be asking yourself, if these things are so expensive, like why are we building them if they're orders of magnitude more expensive? And the main advantage of ion therapy, it's really like physics driven. The primary benefit of using ions in favor of conventional X-ray radiation therapy is they have an inherently favorable depth dose distribution. So we call this a Bragg peak, which you can see here in black for protons. And this depth dose distribution comes about as a result of the fact that as charged particles pass through a medium, they slow down and stop and deposit a large amount of energy sort of at the end of their range. So provided that we select our iron energy to have a range corresponding to the depth of the tumor in the patient, we can deliver relatively large doses to the tumor and relatively little dose elsewhere, simply as a consequence of the favorable depth dose distribution that the ions have. And then if we wish to cover a more extended region with this high dose, all we need to do is modulate the ranges we select for a given treatment to create a distribution known as a spread out Bragg peak, which is this red curve here. So that allows you to get good coverage over a reasonable sized tumor, and you're still just inherently sparing dose to the surrounding normal tissues because the dose distribution is favorable like this. And so here's what that looks like in the context of a patient treatment plan. So here there's two images of pancreas patients. On the left, you have one treated with protons, and on the right, you have one treated with VMAT photons. And really, the main thing to take away here is by choosing to treat with ions instead of X-rays, you're sparing this huge low dose bath, like all around the patient, right? For protons, you don't get any dose distal to the end of the range. You don't get very much dose lateral to the beam. And you also don't need to pick that many beams to get good coverage because inherently the dose distribution kind of gives you that. So, all these things together mean that you're able to spare a ton of dose to surrounding healthy tissues by using ions instead of using X-rays. But there's another main advantage of ion therapy, and it comes about as a result of the fact that different types of radiation produce different patterns of ionization on a microscopic scale. So photons and electrons are sparsely ionizing compared to heavier ions, which are much more densely ionizing. And what I mean by that is that heavy ions, they produce many ionization events in close proximity to one another. So here on the right, you can see an animation from a Monte Carlo simulation that tries to show that. In blue on the bottom are helium ions, and they're producing these red secondary electrons from the yellow ionization events. And on the top, you can see an electron beam sort of in the same setup. But just look at how short the range of those secondary electrons is produced by the alpha particle beam. All of the dose that the alpha particles are depositing are really densely ionizing. And then this becomes therapeutically useful because it tends to be the case that if you have more densely ionizing radiation, that radiation is more biologically effective than sparsely ionizing radiation. So then you might ask yourself, okay, well, why is that? Here, we typically refer to this phenomenon as the LET effect. So LET stands for linear energy transfer. It's defined as the rate at which an ion loses energy per unit distance traveled through a medium. And this is the most common sort of surrogate we use for how densely ionizing a particle is, because if a particle has a high LET, it's losing more energy per unit length as it travels through the medium. And so, compared to a low LET particle, which is losing less energy per unit distance traveled through the medium. And this has consequences when we think of the types of DNA damage that are induced by high versus low LET particles. Because the ionizations are so clustered together for high LET particles, they tend to create more complex DNA lesions and more clustered DNA lesions. And compared to lower LET radiation, which tends to produce sort of less complex DNA lesions because those ionizations are sort of far apart. And since more complex lesions tend to be more difficult for cells to repair, high LET particles tend to be more biologically effective than low LET particles or photons. So then one of the things you might be able to infer from this plot up on the left is another important benefit of ion therapies comes as a result of the fact that they have a favorable depth LET distribution. So here, tumors, which are typically towards the end of the range, are exposed to much higher LETs than the normal tissues upstream of those tumors. So not only do we expect that the doses that the physical doses the tumors are going to receive, have this inherent benefit in the dose distribution, the doses that the tumors receive are inherently more effective at inducing cell killing compared to the doses that the normal tissues are receiving. So there's this additional benefit as a result of the increased effectiveness of ions sort of as they're coming to stop in the tumor. So while it's all sort of well and good that ions tend to be more biologically effective than X-rays, from a clinical perspective, you might be asking yourself, well, how can I actually prescribe ions to a patient unless I know how much more biologically effective than X-rays there are? And this is because almost all of our knowledge about which doses to select and how much dose normal tissues can tolerate comes from our extensive clinical experience with photons. And so in order to figure out what doses to prescribe and what normal tissue constraints to use for a given treatment, this is where the concept of RBE or relative biological effectiveness becomes useful. So RBE tries to account for this differential effect by holding that effect constant and then taking the ratio of the doses required to achieve that effect. So usually this is relative to an X-ray or a gamma ray source, like cobalt-60, or some high energy X-ray source like 6 MV X-rays. Once we can calculate the RBE, we can then weigh the doses we deliver with ions by the RBE to get the RBE weighted dose for a given treatment. And what the RBE weighted dose does is it should give us an indication of the biological effect we would expect from the same physical dose for photons. And since we have a mountain of clinical data with photons, that can allow us to inform our treatment decisions, what doses to prescribe and what our normal tissue toxicities might be. The major problem with this RBE framework, though, is that ion RBE depends on quite a few factors that can vary across a patient treatment field. And so we need to have some sort of model that will tell us what the RBE will be within a given treatment planning voxel so that we can actually plan our patient treatment effectively. Um, so among these effects, for example, as I mentioned before, we need to account for the LET effect, or linear energy transfer. So the data in the literature show that as you increase the LET, you tend to increase the RBE. So you can see this pretty clearly for protons on the left. As you increase the LET, the RBE goes up. However, if you go to heavier ions where you can get very, very high LETs, it seems like eventually you achieve some sort of maximal RBE value. And then afterwards, as you increase the LET, the the RBE goes down. So we call this, or refer to this as the overkill effect. So this is sort of two complicated things we need our model to be able to account for. The fact that as you increase the LET, RBE goes up, but then eventually for very high LETs, it's going to go back down. Another physical factor that contributes greatly to the variability of RBE within a treatment field is actually just the dose delivered. This is a thing that people don't think about a lot, but it's really just a consequence of the way that we calculate a cell survival curve. Here on the right, you can see that for lower dose levels, the RBE tends to be much higher, which at first is probably a bit counterintuitive, but it's because you're kind of in the shoulder region of a cell survival curve, so there's a lot more room sort of to move. And the RBE is just higher if you deliver small doses. And this can have a really big effect when you're talking about the distal edge of an ion beam. So in the distal edge, you have really high LETs, and those high LETs contribute to high RBEs. But you also have low doses because the dose is falling off. And those low doses also contribute to higher RBEs. So in the distal edge of a beam, you can have really, really high RBEs, even if your dose is very small. And then consequently, you can have a pretty modest RBE weighted dose, even if the dose itself is quite small. So just to come back to these data that I showed just a slide ago, again, one of the other things you can sort of glean from this plot, each of these curves is a different cell line. And for each cell line, you get a different answer for what the RBE is. So this is, all across the literature data, anytime you measure RBE in cells, if you pick a cell line, it has a unique RBE response. They're sort of qualitatively similar. They follow the same trends, but the actual values of RBE depend strongly on which cell line you pick. So if you're going to make a model of RBE, you need some way to account for, what cell line or what tissue you're talking about when you're making your predictions. It's not clear that it makes sense to make a sort of global prediction of RBE for all tissues because we know that different tissues have different RBE values. And sort of what's challenging about this problem of trying to account for these cell-specific differences is that we're really wading into the biology territory where biology is very hard and there's lots of unanswered questions about the biological factors driving radiation response. So it's very hard to sort of know a priori what characteristics of the cell are important in driving its particular radiation response. And one of the things that we know is even very small differences in the cell's biology can result in dramatic changes in radiation response. So here I'm trying to show that using some data from my dissertation work. So here I'm showing the RBE response of cells that have a single gene modification. So all of these curves are for cells that are genetically identical modulo a single gene modification. But it just so happens that gene modification affects the cell's ability to do DNA repair, specifically double strand break repair. And so you can see that even for this, relatively small change, a single gene, you get dramatically different RBE values, but also the RBE sort of trends differently as a function of LET. So, if you really want to make a robust RBE model, then you're going to need some way to account for these biological effects, which are very, very large and may in fact even be sort of larger than the physical effects that govern RBE. So before we dive right into the RBE models, I just wanted to slip in this quick reminder of how we actually parameterize cell survival in RBE, since all these models are based on cell survival data. So it's kind of important to understand these parameters. So first, just recall that we use the LQM, this model, to parameterize cell survival. So this is just an exponential function of dose with two free parameters, one that governs a linear dose term, alpha, and one that governs a quadratic dose term, beta. And we like to think of these as single action cell killing term for alpha and the dual action cell killing term, beta. So we call this model a linear quadratic model. It's the model that pretty much everyone uses to model cell survival. Another thing to remember when you're trying to calculate RBE is that you're not calculating differences in survival, you're calculating differences in doses. So frequently, you're going to come across an ugly expression that looks kind of like this. And this is just a result that comes from inverting the linear quadratic model to calculate the dose. So many of the RBE models have, kind of an ugly mathematical formulation. And it's a consequence of the fact that you've encoded the quadratic formula. If you remember back to your high school math, like this is just the quadratic formula codified. So all of your RBE models sort of have this built into it, which is ugly. So then if we actually want to calculate RBE for a given dose level, we do something that kind of looks like this. You have this ratio of doses, and then you plug in that expression that looks like the quadratic formula to get the RBE. And you can do some rearranging, and you get an expression that just kind of looks like this. It's just a simple expression that tells you what the RBE is for a given dose level. So I mentioned this earlier. If you deliver a different dose, you get a different RBE. So that's just a consequence of the fact that your RBE models come from cell survival curves, and cell survival varies as a function of dose, and it varies differently for ions than for X-rays. And so you're going to have this dose dependence in your RBE model that you need to account for. Yeah, there's some more cleaning up you can do in this algebra, which I'm showing here, but I'm really just trying to get to the point at the bottom. Basically, this equation at the very bottom, which is relating RBE to the parameters alpha and beta. And after doing this algebra, you can write the equation in such a way that you can pretty clearly see let's see these terms right here, the alpha over alpha ref and beta over beta ref terms. So when you are creating an RBE model, the trends you're really trying to model are how alpha and beta for ions vary as a function of your beam quality specifier. So in this case, I've written LET, relative to their sort of intrinsic values, the values to X-rays. So these are really the quantities that we're interested in thinking about when we're trying to develop an RBE model. How does my alpha parameter vary with LET? How does my beta parameter vary with LET? Or some other beam quality specifier if you have a better beam quality specifier than LET. Okay, so now to move on to these models. So first I'm going to talk about mechanistic models that are currently used for treatment planning. So mechanistic models are models that are based on arguments that try to explain the underlying trends in literature data, but in terms of like physical and biological mechanisms. So there's quite a few published mechanistic models, but the ones I'm going to focus on today are the two that are actually used in clinical settings, the local effect model and the microdosimetric kinetic model. So the local effect model is used in Germany for their carbon ion therapy centers. And the microdosimetric kinetic model is used predominantly in Japan for their carbon ion centers. So these models, in principle, can be used with protons, but currently no one is using any RBE models with protons. We're all just assuming RBE is 1.1, as I'll get to later. But they are compatible with protons because they just, they're making arguments about ionization density of ions, and they just need to be sort of implemented for a proton setting if you wanted to implement them. All right, so to begin with, the local effect model is a model that was originally based on an ion track structure model. At a very high level, what it's trying to do is predict cell killing based on how ions deposit dose locally according to the track structure of the ions. And that's how it gets the name local effect model, because it's looking at local effects. So the main assumption that is underlying this model is that inhomogeneous doses across the cell nucleus produce the same effect locally as homogeneous doses would. So, right away, that's probably a bit confusing after, I've just told you how microscopic patterns of energy deposition are really important, but bear with me on this argument. So what this model does is, it assumes that uh, the reference alpha and beta values for a cell line describe the probability of a cell being killed by a homogeneous radiation dose, since the doses deposited by photons are essentially homogeneous across a nucleus. But for ions, we assume that the nucleus is the relevant target for radiation damage, and then we go and calculate what the inhomogeneous dose distribution is across that nucleus according to our track structure model and like the fluence of particles that we're exposing the cells to. So we basically have these two cases. We have a homogeneous dose distribution case and an inhomogeneous one, and we're curious to see like how the survival changes when you go to inhomogeneous doses. So here's where the thinking about the local effects being the same in these two cases is important. If you think about an infinitesimal volume within the nucleus, then the ion dose within that infinitesimal volume is essentially homogeneous. And so the radiation response in that subvolume is governed by the same alpha and beta values that govern homogeneous doses to the whole nucleus. So then if you want to calculate the average probability to inactivate a cell across the whole nucleus, all you have to do is integrate this expression down here across the whole nuclear volume. So you can see what this expression here is trying to do. For an infinitesimal volume, dV, we're calculating the surviving fraction for the dose in that volume. And we're averaging that surviving fraction essentially across the whole volume. And it's important to remember here that while we typically think about surviving fraction in terms of a population of cells, it also has a very intuitive meaning in the context of a single cell, which is just the probability of that cell being inactivated by a dose of radiation. So that's kind of why this expression works, because we're calculating the average probability for a cell to be inactivated across all of the dose it receives across its nucleus. So that, in a nutshell, is what the LEM is doing. We look at the local infinitesimal doses, calculate how these would inactivate a cell if they were homogeneous doses, and then average across the whole nucleus to get our probability of inactivating a cell, which you can then extrapolate to the surviving fraction, which is just the average number of cells that are inactivated. So, this model has undergone a number of iterations. More recently, they've been adding terms to try to incorporate additional cell biology factors, like notably the induction of DNA double-strand breaks. But currently, LEM1 is still what we're using in the clinic for treatment planning. Okay, so suppose you actually wanted to use LEM to make some RBE predictions. Like, what do you actually need? So here, first, you need 5 input parameters to describe the beam quality. You need the beam energy, you need the LAT spectrum, and then as biological parameters, you need the reference alpha and beta values for the cell line of interest. And there's also a dose threshold parameter, but that is trying to describe the dose limit. So for very high doses, where the linear quadratic model sort of breaks down and the cell survival curve becomes purely linear. You'll also see there's this very large group of default parameters that go alongside your actual input parameters. And these default parameters are there to it's basically a number of physical track structure parameters and parameters governing, induction of DNA double-strand breaks for the more mature models, and some parameters describing the cross-section of the nuclear target. And I think what's interesting about these is, you might notice that some of these default parameters seem like they ought to be, input parameter input parameters, like they're cell line specific, right? Like the size of the nucleus varies from cell to cell. Like that should be cell line specific. Um, but here they've just assigned them as fixed values, and the main reason for that is these parameters are extremely difficult to obtain on a cell line to cell line basis. Like they're not typically published when you publish cell survival experiments, and measuring them is very challenging. Um, so, essentially we have to just approximate them by choosing these default values, which, kind of are moderate values that work reasonably well across all cell lines. Um, and so this kind of demonstrates one of the main limitations of mechanistic models, which is that, we often find ourselves in a position where we can't really obtain the parameters we really want to use the models because they're so sophisticated. And so consequently, if you want to do a cross-validation of different models, you're in a position where even if there's a reasonable amount of survival data in the literature, you actually can't run LEM or MKM on the data that exists in a fair way to compare the models because you don't have all the input parameters. So you're sort of forced to make some approximations in the model, and then you don't know when you're doing your validation whether the results you got are a consequence of the approximations you made or whether they're features of the model. If one model is more accurate than the other, maybe it's because you didn't have to make as many approximations, but the other one is actually truly more accurate if you had the parameters that you couldn't actually get. So it really makes it challenging to say which of these mechanistic models is the best, I guess. All right, so the next model I'm going to talk about is the MKM model. So this model looks at this problem sort of from a similar perspective as the LEM, but it considers the microscopic deposition of dose by the ions sort of a step further by trying to explain how the microdosimetric properties of the ions increase the likelihood of inducing lethal DNA lesions. So in the case of the LEM, in its first formulation, you're just kind of looking at the dose distribution across the nucleus, which you said was the target. And now, like MKM is more specifically saying, no, I actually care about lesions and how likely it is to induce lesions. So it's a little bit more sophisticated in that sense. So for the MKM, we assume that the likelihood of potentially lethal lesions forming close enough to one another to become lethal. So the terminology used in the context of this model is like within the same nuclear domain. So we assume that the likelihood of potentially lethal lesions forming close enough together increases as you increase the ionization density. And also that the distribution of lethal lesions per cell and then also across a population of cells follows a Poisson distribution. So under this assumption, you can denote the expectation value of the number of lethal lesions induced per cell. And we'll just call that N. And that you can do for any type of radiation. Doesn't need to be ions. You can just say the average number of lethal lesions in my population of cell for a given radiation field is this value N. Since we are assuming that the distribution of lethal lesions across a cell population is Poisson distributed, that distribution should look basically like this, a Poisson distribution with the Poisson parameter n. Now, by definition, lethal lesions kill cells. So the only way that a cell will survive a given radiation dose is if it receives 0 lethal lesions. And so the surviving fraction of cells should depend on n, sort of like this, where you're looking at the proportion of cells that have received precisely 0 lethal lesions. We can then relate this to the linear quadratic model because we now have a relationship between, lethal lesions and surviving fraction. And so you get a relationship that looks like this, where you can relate the expected number of lethal lesions that ions induce to the alpha and beta parameters that we, perhaps know because there are reference parameters for a given cell line. So all we really need at this point is we need some way to modify the alpha and beta input parameters to account for how increasing ionization densities and also like the size of the nuclear domain, like the region in which those increasing ionization densities actually matter. We just need some way to figure out how those modulate alpha and beta to figure out the number of lethal lesions we expect our ions to induce, and then we can very easily calculate survival in that case. So then what the MKM does is it assumes that the modulation to the alpha and beta parameters only occurs in the alpha term. Since beta sort of already implicitly tracks dual action cell killing. And so this model leaves beta invariant and sort of just focuses on alpha. The next thing it does is it uses a microdosimetric quantity to track changes in ionization density. So this parameter, the dose-weighted mean lineal energy, or YD here, this is a microdosimetric quantity. It's similar to LET, but it has some subtle differences since it's a microdosimetric quantity. The main thing is it looks at energy imparted as opposed to energy lost by the ion. But it is actually, a fairly complex quantity. There's like an hour-long lecture somewhere on YouTube that tries to describe the difference between LET and dose-weighted mean lineal energy. So there are a lot of subtle differences, but for the sake of your understanding, you can think of it similarly to LET. Um, so so what this model then does is it just uses a simple scaling factor, this like 0.204 here, to relate changes in ionization density, which is parameterizing in terms of YD, um, over the nuclear domain, which in this case is D. Um, yeah, and it's using the probability of dual action cell kill beta to sort of give an indication of that. So what this model is really, sort of the reasoning behind this formulation. If you look at this equation, you're basically making an argument that as you increase the ionization density over some small volume, the probability of getting dual action cell kill, which is what beta governs, increases. But then since these ionizations are induced by a single particle or a single particle track, um, or like simply because the lesions themselves are lethal, you can think of this as a single action cell killing event. And so like all of this modulation just goes straight into the alpha term because that's the term in the linear quadratic model that tracks single action cell killing. So it's actually a relatively simple formulation at the end of the day. It's just this simple, you know, formula that modifies alpha. The challenge though is that getting these microdosimetric parameters is a pain. All right, so when it comes time to using this model, what do you actually need? The MKM has 6 input parameters. You need a beam quality specifier, which is this um, lineal energy transfer quantity. Um, you need 5 cell-specific parameters. You need the size of the nuclear domain. You need the nuclear cross-section. You need the reference alpha and beta values. It also needs a parameter that's the RBE in the limit as linear energy approaches 0. So here there's clearly far fewer parameters that are needed with LEM. But like LEM, these parameters are pretty challenging to obtain. In particular, like dose mean lineal energy is rarely reported alongside survival data in literature. Like just LET is far more common to have. So it's very difficult to find survival data in the literature that you can actually sort of test this model on because you don't have the beam quality specifier, and to obtain it is extremely challenging. Like you would need to have a Monte Carlo model of the beamline that the irradiations were performed on. And generally, unless you work at that institution, you do not have that. So it's very challenging to actually get these. And then similarly, there's a bunch of these cell-specific parameters that are likewise difficult to obtain. They're not published alongside survival data, and measuring them in the first place isn't trivially easy. And even if you wanted to go measure them, you would need to have a functioning wet lab and the expertise to actually make these measurements. So it makes using these models very, very challenging, sort of broadly. If you want to use them on a cell line you don't really know much about to begin with, it's really, really tricky. All right, so just to wrap up these mechanistic models, the basic idea behind them is they try to describe how microscopic dose deposited by ions increases the likelihood of inducing cell death per unit dose. Sort of the main attraction of these models is that they're informative of the underlying radiation biology. So, since they try to describe these changes in RBE as a function of the actual physical mechanisms, the accuracy of the predictions we get from them is sort of informative about the degree to which these radiation biology trends are true. So, these models, help us understand the radiation biology, even if they're not, even if they're not perfect, or if they're, you know, even if one model is better than the other, they can always tell you something about the underlying radiation biology, which is currently not very well understood. Um, the big drawback to these mechanistic models is, ease of use and implementation. You know, it's very challenging to get the input parameters. Um, and as time goes on, these models have become increasingly more complex because, we are understanding the radiation biology more and more, and that motivates us to include additional parameters in these models to try to account for that radiation biology. Um, but as the models become more complex, it becomes more and more challenging to determine, which model is actually doing the best job, because you don't broadly have access to these very sophisticated radiation biology parameters you might need. And it becomes more computationally expensive to actually run them once you add more parameters to them. All right, so now onto protons. So for protons, there's a whole other can of worms. So we sort of know that RBE can vary quite dramatically within patient treatment fields, even for protons. But currently we just use an average RBE value of 1.1 everywhere, and we get that value, as you can see on the right, essentially from just taking the average across a wide range of conditions and finding that average to lie around 1.1. But if you just look at these data, you can see there's a lot of variability sort of buried in this data set. And given that we know there's tons of factors that influence ion RBE, it's certainly far from settled that just using the average RBE is the best way to handle proton RBE in the clinic. But there's a couple of things I want to point out as to why we still in the clinic haven't departed from RBE equals 1.1. And the first is that for protons, the RBE values aren't very large to begin with. So they don't deviate greatly from the average value of 1.1 over sort of the possible range of deviations. And when you consider how much noise there is in the measurements to begin with, like you can just look at the right on it and see how big those error bars are. Like it's not obvious that using what's going to fundamentally be a noisy RBE model, since it's trained on noisy data, to predict the RBE is actually going to improve anything. And the second thing is that assuming RBE 1.1 is 1.1 everywhere is kind of conservative for treatment planning. We know from the LET effect that RBEs are going to be lower in normal tissues upstream and higher in the tumor, which is in the Bragg peak region. So our proton plans should yield therapeutic ratios that are actually somewhat better than we planned, which we're happy about. Um, that being said, there's a recent or relatively recent task group report which came out in 2019. So TG256 is the AAPM American Society or American Association of Physicists in Medicine task group report on proton RBE in this case, which is what number 256 is about. And so they recommended in 2019 that we should stick to 1.1, because of all these complexities and not knowing which RBE model is best to use. But they do note that there are some situations where considering a variable RBE might be appropriate. And the most obvious case here is at the end of the proton's range. So this is because of the synergistic effect between the synergistic effect of the LET effect, and as you lower doses, you also tend to increase the RBE. So at the end of a proton's range, you get RBEs that are considerably higher than 1.1 because of these synergistic effects. And so if you put critical structures in the distal edge of the field, they might get considerably larger RBE weighted doses than you planned for. And so accounting for variable RBE in these cases might help improve clinical outcomes. That being said, you might say to yourself, well, I mean, this is such a small volume in the distal edge of the beam that's going to receive these high RBEs. Like, shouldn't we be able to account for this just by using a margin? And the answer to that question is not always. So here's an example of a study I worked on where we used variable RBE models to retrospectively assess treatment plans in patients treated with protons. So here on the left, you can see the treatment plan for a head and neck patient under the assumption that RBE is 1.1 everywhere. And importantly, you can see the 54 gray isodose line in green is off the brainstem in black, which is our treatment planning constraint. But when we consider the variable RBE on the right, since the distal portions of the beam are abutting the brainstem, there's a significant portion of the brainstem receiving much more than 54 gray of RBE weighted dose. So it's data like these that really point out the potential limitations of just assuming that RBE is 1.1 everywhere for protons. Now, fortunately, in the case of protons, due to the great availability of cell survival data in the literature, it's been relatively straightforward to develop empirical models based on the trends in the data. So you can see here on the right, much of this effort has been focused on trying to understand the trends in the ratio of alpha or beta to the reference values as a function of LET. So here I'm going to walk through the progression of a few of these models, since I think it's going to be quite instructive to let you see how, see what the trends people are actually modeling. So the first model I'll discuss is by Karabe et al. So the important thing they noted in their work was that RBE has a minimum and maximum value, which occur as the dose tends to 0 or to infinity, and that the resulting limits are very closely related to terms in the RBE equation. So we can actually just rewrite the RBE equation in terms of RBE max and RBE min. And then it's just a matter of characterizing how RBE min and RBE max vary as a function of LET to create an RBE model. So they went ahead and plotted RBE max and min versus LET using some literature cell survival data. And what they noted was that the two seem to depend linearly on LET. However, their data was just a single cell line, so they didn't know how cell-specific parameters like alpha and beta might modulate this behavior further. Um, and accordingly, they just assumed the a reciprocal dependence of the alpha beta ratio um, on to modulate this effect in a like cell line specific way. This is based on similar observations in the context of carbon ions. So building on this work, there was another model published by Vettenberg et al. And what they noticed is that alpha over alpha ref varies linear with LET. And they assessed this over a number of cell lines with different alpha beta ratios to determine sort of how this alpha beta ratio will affect will influence the slope of this dependence. And they did find that a reciprocal dependence on alpha over beta is suitable. So they used this equation to model the trends they observed. They couldn't find a statistically significant dependence on beta or of beta on LET. So they just assumed that beta was invariant with LET. So this is kind of similar to what MKM is assuming. Um, so this results in a model that looks kind of like this. It's relatively straightforward. It only has one free parameter, Q, which they found to have a value of 0.434. So, this is actually an incredibly powerful model when you consider the fact that it only has one free parameter. If you're considering sort of, accuracy of the model versus number of free parameters used in its construction, this model is very, very powerful, even though it's, very, very simple. Building on this work, McNamara et al., they used a similar function to Karabe, but they allowed, there was like a unity term, a one term in the alpha over alpha ref term. They allowed that to be a free parameter, which they called P naught. And they also decided to model the beta dependence by assuming it depends linearly on the square root of the reference alpha over beta ratio. So that yields like this expression right here. They were able to add all these extra terms to their model. By terms, I usually mean free parameters. They have far more free parameters than the other models. And they were able to do this because they collected a huge data set, nearly 300 paired cell survival experiments worth of data to train their model on. So that sort of justified the use of all these extra parameters in creating that model. So that, the final sort of formulation of model is this big expression that you see here on the bottom. And this is kind of regarded as the best empirical model we currently have for proton RBEs, since it uses a relatively small number of free parameters, just 4, and it's more accurate than the previously established models because it's trained on this huge data set. Now, I'll briefly mention Mehrani's model. So, he sort of came at this problem with somewhat of a fresh perspective and had the idea, well, why should we make assumptions about how RBE max depends on LET? Like, why don't we just throw the kitchen sink at the problem and try a ton of functions and see what functions worked best? So he tried a handful of functions to model RBE max's dependence on LET, but ultimately he found that it's hard to justify more than just a simple linear expression given how noisy the data is. And so this sort of marked the end, I guess, of this type of approach, since it's very hard to get more sophisticated trends in the alpha or beta parameters just because of how noisy they are. So here I'm kind of showing just that. Like, this is how noisy the alpha and beta parameters are. Like, just look how big the error bars are. You can't do much better than just putting a line through them and saying, this is my trend. So towards the model that I ended up creating, just to shamelessly plug my own model, sort of push this forward a bit, we asked ourselves the question, well, how necessary is it to actually model how alpha and beta specifically vary with LET? And the reason you'd ask this is just because of how noisy these data are. It's going to be hard to do much better than a straight line because of how noisy they are. So let's try to model something else. Um, so if we had some way that we could get away without explicitly having to model alpha and beta, and how they depend on LET, we might be able to do a lot better because we could have a much more sophisticated function to describe the trends. Um, so we thought, well, what about less noisy radio sensitivity metrics like the dose for 10% survival, D10? And the reason why thinking about D10 makes sense is it's based on this old radiation biology paper by Suzuki et al. So they showed that for the survival endpoint D10%, you get a very strong linear correlation between survival to X-rays versus carbon ions. That's what these plots are showing. And given how strong these correlations seem to be, if we can estimate D10 to X-rays, which we often should be able to do if we have reference alpha and beta values, and we should be able to estimate D10 to ions based on this trend, and then get the RBE value. But at this point, you might be saying, well, what if I'm interested in a survival level other than 10%? How am I going to do that just using this trend? Well, data that we collected showed that these correlations between radio sensitivity to ions versus X-rays occur regardless of the endpoint you selected. So here I'm showing it for 10%, 37%, and 50% survival. So that's nice. The next thing you might say is, well, what if I don't have data at the LET I want to predict? Like, how do I know what the trend line will be? Well, the data that we collected also shows that the slope and then maybe also the intercept of this correlation varies regularly as a function of ion LET. So it's just a matter of modeling the trends. So to spare you the gory details of how we got there, we ultimately did a bunch of modeling. We ultimately found that the linear correlations can be described by functions that look like this. So here you can see this is a function that just relates the dose required to achieve a given survival level, SF, to protons. It relates it linearly to the dose required to achieve the same survival level. But we found basically an exponentially decreasing function of the slope. And we found a linearly increasing function of the LET to describe the intercept of that relationship. And then we did it for two biological endpoints. The dose required to achieve 5% and 37% survival. So that's what those are. D e to the -1 is e to the -1 survival, and then d e to the -3 is e to the -3 survival. And it sounds a bit obtuse, but you pick those values because they simplify the final expression a bit, because basically because the log of e to the -1 is just 1 or -1. Yeah. So once you have these expressions, you basically just plug them in to these seemingly cumbersome expressions of alpha and beta. And then that allows you to calculate the RBE. So even though this looks a bit cumbersome, fundamentally it is just an algebraic expression that relates alpha and beta to X-rays to alpha and beta to protons. And importantly, it just requires 3 input parameters: the reference alpha and beta values and the dose-weighted LET. And the model itself contains 6 sort of free parameters. So it's a few more parameters than McNamara was able to include. And we are sort of able to get away with this because we're modeling less noisy trends. We can justify adding additional free parameters to model those trends. So in our paper, we compared the predictions from these models against literature data. So just to briefly go over these up. So yeah, we compared our model to the McNamara model, the Vettenberg model, Andrea Meirani's model. So you can see the predictions made by these models across basically the same data set that McNamara had used, plus new data which has come out since their publication. So all these black points represent a single prediction. And sort of what you're looking at in these curves, qualitatively, a good model these predictions should sort of hug the truth line red and sort of follow it up and down it. And I mean, you might argue for none of these models that's really the case. There's a lot of noise in the data, but I think you can kind of look at it and qualitatively see that our model seems to perform the best in these cases. Um, if you go ahead and calculate the sort of goodness of fit metrics, so in our case, we used two metrics, the Bayesian information criterion, or BIC, and then chi-squared over nu, which is chi-squared per degrees of freedom. So these are both goodness of fit metrics that try to account for the number of free parameters used in the model construction. Because our model used more free parameters, we wanted to make sure that we weren't getting a more accurate prediction simply because we were overfitting and using too many parameters. But all these parameters in the case of our formulation, it seems to be on average sort of the best. Importantly, the places you can see it sort of performing sort of appreciably differently from the other models is we don't have issues predicting very, very high RBE values, like you can see like sort of the rightmost points. And then our model is also capable of predicting RBEs less than 1, which have been observed in the case of protons. So that's a nice feature of our model that it can actually predict those things. But that being said, generally the performance is kind of better, or yeah, the performance of these models generally isn't great. It's on the order of 15 to 30% accuracy. And when you're considering that, the RBE is pretty close to 1.1 to begin with, it's not obvious how useful this actually is. All right, so just to kind of wrap this up, the empirical proton models, we saw that, generally we've been trying to focus on characterizing how alpha and beta vary with LET, but due to how noisy the data are, it's very challenging to do that. And what I showed in the paper I recently published with my model was that you might be able to get away with using more free parameters if you model less noisy metrics like D10%. But the prediction accuracy isn't great compared to the value of RBE. So it's not really obvious how useful this, I guess, is. So just, some final thoughts about RBE modeling. RBE modeling is hard, and the reason for this is that we don't fully understand the radiation biology to begin with. So that's kind of the big challenge here. It's unclear what beam quality specifiers to use because the radiation biology isn't very well known, and the biological data are noisy, so it makes training and validating these models incredibly difficult. So for protons, it's really unclear if it's where you would consider departing from RB equals 1.1 and whether it's even appropriate to do so. And then there's final like low-hanging fruit criticism. All these models are trained on in vitro data, and currently we don't know the extent to which this can actually be mapped from cell survival data to like patient in vivo data. So that's a big issue, I guess, in the future of RBE modeling. So with that, I just want to acknowledge a bunch of people who contributed to some of the data I show and shamelessly plug a baby picture. So I guess I can take questions if people have questions.